Professor Lee, before we turn to look at HIV and AIDS, there's just one matter from yesterday I wanted to go back to first. You told the inquiry yesterday, or your evidence may have given the impression, that in the period 83 to 84, and up until the point really when you became a consultant in 1987 at the Royal Free, you had very little day-to-day clinical contact with patients.
Yes, obviously I would have had contact with patients because we were in the centre, and there were some patients who needed to have blood tests, and I can particularly remember there was a patient who I described yesterday, an elderly gentleman who had an undiagnosable chest infection that I did see. I remember that. So I must have had an honorary clinical contract to work in the hospital, but that wasn't my primary role. The vast majority, I spent 4 days a week. I had no on-call commitments, and the vast majority of my time was spent looking at notes and analysing all that.
Okay. Could we just look at what you said about your work in an interview you gave in 2015 as part of the Royal College of Physicians Oral History Project? So it's THOM 601, please, Henry. If we go to the bottom of page 26, please, Henry. I just want to show you a handful of passages and check whether these accurately convey the balance of your workload. So the very bottom of the page starts, now my primary task when I went there was to follow up patients with haemophilia who'd had their first treatment ever with a large, sorry, I'll wait till we go to the top of the next page. Large pool clotting factor concentrate, that's factor 8 or 9. And then, and that's the research work that you've described, I think. And then if we go a few lines down, about 10 lines down, you should see a passage beginning. So my job was to follow up these patients, and they were quite well. They just, some of them had had an operation. Some of them might have had some trauma, which was why they'd had it. But I used to see them take the blood, and then that was tested, and we also used to store it. So there's that description of seeing patients taking bloods. And then if we go to page 28, please, Henry. About 7 lines down from the top, I'll just zoom in. There's a passage beginning this, and then alongside all this comes this strange immunological problem. And I used to look after the patients as they presented. Although I was a pathologist by training, I had done a lot of general medicine, and I was quite a good physician, and they were presenting with strange infections. And then you go on to refer to the patient who I think is the one that you've just mentioned. If we go a number of lines further down, so it's 4 lines up from the bottom of the screen as it currently is, if you leave it there, Henry. It says, so I was seeing these patients, and then there's a reference to the Haemophilia Society. And then if we go to the very bottom of this page, you say this. So to go back to my patients with haemophilia in this, next page, top line. In this 2 years, I was looking after them clinically, but also I was doing the research. So the 2 years there are 1983 and 1984, aren't they?
Yes, I think I would like to just set this in context a little. This is 2015. I've been retired 10 years, and basically I hadn't done any clinical work for 10 years. The Royal College of Physicians History Project was actually to lay down a history archive, and they were particularly interested in the position of women in medicine in the 1960s. When I was at Oxford doing my undergraduate degree towards medicine, there were 10 women. You weren't allowed to have any more than 10 women in the whole university doing medicine. So that was the basic thrust of it. The interviews were done by an oral historian, And I think in total in this oral history project, there were 3 days of continuous, she was asking the questions and I would dictate in the phone. I would also like to stress that, in no way was this saying under oath. I was just reminiscing in my own house. And what has happened in this inquiry is that I've actually read all the papers and begun to remember more. It's really very difficult, remembering back 1983, 37 years now, then it would have been 32 years, I think. So I think what I would say now in memory is that most of my 4 days, I would say 80% of my 4 days was spent looking at information and analysing information. I didn't have clinical responsibility in the sense of decision making, but I was in the department. I was a qualified doctor, and I had an honorary contract. So if there was a problem, I could be asked to see that person. The main clinical care, the first person of contact, as I explained yesterday, was the junior doctor rotating through the department, who was a senior registrar in haematology, and he or she was there to train in haemophilia care. So if he or she didn't know anything or had a question or a query, who would they come to in the department who knew something about this strange condition that was coming? Who in the department would they ask about the hepatitis? The hepatitis, by the time, and I think I explained this to you yesterday, the study was from April 1978 to March 1983, and I actually took up my job at the end of January 83. And as I recall, and I'm just recalling, trying to remember 37 years ago, I think there were about 2 patients left who still required to be seen every 2 weeks to take their blood sample. So I hope that answers your question.
Just 2 follow-up questions, if I may. The first is, you in your answer a moment ago, you posed a question, a rhetorical question. The senior registrars, who would be seeing patients.
Sometimes it was a registrar, it wasn't always a senior.
And you posed a question, who if they needed to speak to someone or or discuss something, who would they ask? Is the answer to that question that they might come and talk to you about this strange new condition or about hepatitis?
They might come and talk to me, but clearly and I tried to explain this yesterday, the Haemophilia Centre worked as a multidisciplinary team. It had to, because there was so much work coming and so many disciplines that we interacted with. There were, as I said yesterday, there were the nurses, there were the counsellors, family therapists, there was the junior doctors, there was the physiotherapist, there was the people that we interacted with, like the orthopaedic surgeon, the liver doctors, and later the HIV. So when I say they came and asked me probably primarily, but clearly the person who had the clinical decision-making around that patient was Dr. Kernoff.
Yes, and I'm not trying to equate your role in any respect with the role of Dr. Kernoff. I'm just trying to understand roughly, and I know I'm asking you about events a long time ago, how much time you spent seeing patients, because your answers here suggest that you did at least spend some time with patients.
Yes, I just said I spent 4 days a week. I'm sorry to bore you with domestic things, but it just gives you an idea of the fact that I was semi-part-time. I used to deliver my children to school. I used to get to the Royal Free at 10 o'clock in the morning, Monday to Thursday, and I used to leave at 5 o'clock. So, that's not a very big clinical responsibility. And I had a desk in the corner of one room, and I spent most of the day sitting at this desk, looking through notes, looking through results and things. Just remember, we did not have a computer. It was quite detailed, sorting through numbers and things that you had to do.
And you gave an estimate, and I understand it's only an estimate, that about 80% of your time was spent on the research work. So would it be fair to infer that approximately 20% of your time may have been spent in more direct patient interaction?
It may have been. I think the other thing that should be recorded here is that the organisation of the Haemophilia Centre, I did say yesterday that Dr. Kernoff was really rather ahead of his time, having a management committee that managed. But what he also did, we had lunchtime meetings. On a Tuesday, there was a lunchtime meeting of appropriate people to discuss. It was called a social work meeting. But essentially, it was to discuss the needs and requirements of, as the time went on, of people with, as it turned out, HIV infection or AIDS, and hepatitis or haemophilia problems. You know, people had to have cars, and sorting out that. There were little children where maybe the school was being difficult about the child keeping going there and keeping treatment there. And the nurses would be at that meeting. You know, we had a nurse that went into the community to train the parents, and that might be something that we would discuss at that meeting, because clearly, and as many people in this room will know, it's not easy injecting yourself, and it's certainly not easy for parents to have to inject children, and it takes a lot of time to do that training. So this meeting was a clinical meeting, if you like to call it that way. So that was on a Tuesday lunchtime. And on a Thursday lunchtime, we had a almost total department business meeting. And the important thing about that meeting was that in the week ahead, we would be seeing people, and the laboratory, particularly if we had, you know, we were having new referrals all the time. So if somebody had a bleeding disorder in some small district general hospital in Essex, that haematologist would refer that patient for investigation in our centre. So this lunchtime meeting on a Thursday, we would have a sheet of paper telling us what was happening next week, because the laboratory had to do these tests, and we had to make sure that they weren't going to have a problem with the tests. And we also needed to know whether everything was organised for the clinics. So it was a total comprehensive care, and the whole team were involved, not least the receptionist. You know, there's no computers, so she's got a book where she's having to book people's appointments and know who's coming or who's not coming, and there are telephone appointments. So it's very difficult to it wasn't like, you know, I think probably you may have a sort of idea of a regular outpatients, you know, the doctor sitting in a room and the receptionist here. It wasn't like that at all. The centre was self-contained with the whole team in it, and everybody knew what was going on. Communication was essential. We had a little ward area where people were seen. There was a children's room. There was a room where the family therapists could talk to patients. So I don't know if that helps.
And where physically was Dr. Kernoff located?
He had his own room.
But as part of the self-contained centre?
He had his own room in the centre. I explained yesterday, the last thing he did, before sadly he had this huge myocardial infarction, he had got agreement from the hospital to have an extension built. And that was paid for by what was called the Catherine Dormandy Trust, which was money that Catherine Dormandy had put in trust that was given mostly by property development developer who was the father of somebody who had severe haemophilia. And that agreement was there. So after that extension was built, the extension, I think I said this yesterday, the extension provided consultant rooms, a room for the family therapist, and the notes were put in a huge area in filing cabinets, and the secretaries would sit between the filing cabinets. And at that point, Dr. Kernoff wasn't there anymore, clearly. I had a room at the back of the centre, a windowless room, and I moved to the front. Dr. Kernoff's room became the children's room, and it was set up as a special room where children could be treated. That's going forward to 1994.
Yes.
But in the period you're talking about, 1983, he had his own room.
Thank you. I wanted to then move to the question of the risk posed by AIDS to haemophiliacs. You've said in your witness statement, and indeed in your Lindsay evidence, that your first awareness of this may have been a Lancet article in April 1983. We just...
Sorry, what?
I'll find the reference in your statement for you, Professor Lee. So if you look at paragraph 37 of your statement, it's page 28. Henry, it's WITN 0644058. And if you could go to page 28, please, Henry. Bottom half of the page. In answer to the question, how and when did you first become aware that there might be an association between AIDS and the use of blood products, you referred to your answer in your evidence to the Lindsay Tribunal, and then effectively you replicate that answer. So far as I was aware, the first indication of the transmission by blood transfusion of what later became known as AIDS or HIV was a publication in the Lancet on the 30th of April. And then you say you don't think, excuse me, you don't think you were aware of the publication by the MMWR of the 10th of December 1982. Can I just look with you at a couple of documents between December 1982 and the 30th of April? Henry, could we have PRSE 0002410, please? This is an article in the New England Journal of Medicine, 13th of January 1983, AIDS and Preventive Treatment in Haemophilia. And it's by Jane Deforge. And I'm fairly confident you're familiar with it because you've cited it in later articles that you wrote. Did you read this at the time, Professor Lee?
I think I must have done, but I don't remember.
We know also, if we have on screen, please.
I think this is January 1983. Yes. I think I'd like to go back to something you said at some point, and maybe it was questioning Dr. Colvin, but you rather suggested that everybody knew that AIDS was a problem in January 1983. And I don't think that is true. It is certainly true that there were cases of AIDS that had been reported in people with haemophilia, but there was still debate about whether those cases were a problem because of the immunological damage that concentrates had come and made some people more sensitive to AIDS. And to go back to this paper that you're referring to in the Lancet, which was actually July the 16th, 1983, I think, if that's the one you're referring to.
No, January the 13th, 1983, the Deforge article.
Oh, sorry, that's this one. Okay. Well, I just want to go back on my comment about there was a suggestion that, it was all cut and dried, that we all knew that people with haemophilia had got AIDS from treatment. It is certainly true that there were people with haemophilia who had got AIDS, but it was still being debated about whether the immunological change in some people had made them more sensitive to getting it. And in the original presentation of HIV, people had what was called a lymphadenopathy syndrome. And if you go back to this my paper that was published in May 1983, those data I presented in a session at the World Federation of Haemophilia in Stockholm in 1983. And there was an emergency meeting in the lunch hour, an hour's meeting of haemophilia treaters from all over the world, and of course patients were there, and because the World Federation of Haemophilia has treaters, patients and doctors. And there was a huge discussion about lymphadenopathy syndrome. When these data that I presented were shown, we had shown that people who had haemophilia A had immunological change, and that's the change at that time. How we measured it was T4, T8 ratios. They're now known as CD4 counts, the T4 count. And when that became low, that was represented immunological depression. The people with factor IX deficiency did not have this in our patients. And we didn't know why that was. And the suggestion was that it was the manufacturing process of the factor IX. And in fact, so this is June 1983. These data are being presented in a room of international haemophilia treaters. There was still debate in that presentation, because I only had 2 slides. Everybody was asked to bring slides so that people could understand what was happening. So there was still debate going on about this immunological change. And certainly in the patients themselves, they presented with immunological change. The other thing I would like to comment on, I think you commented on it yesterday, or maybe it was when Brian Colvin was giving evidence, but there was a paper by Armen where a child had got HIV from platelets. That paper was passed around numerous journals and they turned it down. The head of the transfusion service in America actually wrote a leader, and I don't have it at hand now, but I can certainly pass it on to the inquiry afterwards, where he disputed any notion that blood transfusion could transmit AIDS. And it wasn't until a paper that was published in the New England Journal in 1984 that definitive proof came that blood transfusion caused AIDS. And I'm sorry to go on about this, but it's important. If you would like to can I do this, or can I interrupt this?
Certainly, but I do want to take you back afterwards, please, to
Yes,
January of 1983.
The paper is, I think this is your number, 644090.
What's it called, please, Professor Lee?
It's called Relationship Between Blood Product Exposure and Immunological Abnormalities.
No, it's 064, so it's WITN 0644064, please. This is your research with Dr. Ritzer. Is that right?
Yes.
Yes, we are going to come on to this, but please do make the
Well,
observation
what
you
I
want to
just
make.
want to make the point is if we turn to page 170, which is the last page.
Page before that, please, Henry.
This is a discussion. Actually, before I say that, this paper was received by the British Journal of Haematology in June '84. It was accepted on the 17th of October 1984, and it was published in May 1985. But what it's discussing here is that immune suppression produced by repeated exposure to clotting factor concentrates lowers the threshold for infection. It's throwing that out. Now, at the time this was written, the knowledge was accruing, but I can tell you that in 1983 there were big debates around lymphadenopathy syndrome. So there was an emerging experience, but it certainly wasn't cut and dried.
Yes, I think, Professor Lee, I don't think I've ever put to Dr. Winter or Dr. Colvin that anything was cut and dried in 1983. The proposition I put to them, which they assented to, was that by January 1983, clinicians involved in the care of those with haemophilia should have realised there was a significant risk that blood products might transmit AIDS. Would you disagree with that proposition?
I think disagree is probably a too strong a word. I don't think it was cut and dried.
Would you agree that by January 1983 there was evidence that blood products might transmit AIDS?
There was some evidence, certainly. If you have people with haemophilia having this strange syndrome.
I don't know if it's any help, but in either your presentation on the knowledge of risk or on Oxford, you told me that in December 1982, Ritzer had observed that all HCA directors knew that there was a real risk that AIDS could be transmitted by an infectious agent carried by blood products. That appears to have been his view, at any rate, at the end of 1982, if that helps.
I think what if you turn on that same paper, the Ritzer paper, to page 168, it's the beginning of the discussion. And I'm sure we're coming on to this because you're going to be discussing the document. The recognition that many asymptomatic patients have laboratory abnormalities resembling those detectable in AIDS has raised the possibility that these patients may have a condition representing a prodromal or form fruste of AIDS. Whether or not this is the case, it seems beyond doubt that the abnormalities we and others have found in haemophiliacs without AIDS are caused by exposure to blood products. What that's telling you is that our experience at that stage was that a large number of people were demonstrating immunological abnormalities, but whether they were all going to go on to developing a form of real AIDS was debatable, and people were debating it. It's a bit like saying whether everybody who got non-A, non-B was going to get liver cancer. And I think I would also like, while we're on that page, so that we don't, just to give you an idea of the people here, the patients. Can we?
Yes, of course.
So this was our experience at the time that this paper was submitted in June 1984. This was clinical experience of the patients. So we had patients with lymphadenopathy, the lymph nodes, which is this idea of a lymphadenopathy-associated syndrome. We had somebody with an opportunistic infection. We had somebody who'd lost weight. We had somebody with a septicemia, and another one with herpes zoster. What that's showing us is that there's undoubtedly immune abnormality in these patients, but as the knowledge was emerging through that time, it wasn't entirely clear whether this was going to be something that transmitted into a full-blown AIDS. We didn't know.
Before we return to January 1983, whilst we're on this paper, Professor Lee, is it then your evidence that as at June 1984, when this paper was submitted to the British Journal of Haematology, you and your co-authors had still not reached the conclusion that what you're describing here was most likely to be AIDS?
I think you could say that at that stage.
We'll come back to
And I just would remind you again of the patient that I saw in 1983, the elderly gentleman. He died at home. His chest X-ray was complete whiteout. And, in retrospect, there's no doubt that that was pneumocystis carinii. So that was AIDS. The other thing that, was happening at this time, we didn't have a test. So the definition of AIDS was very vague in a way. There were these lymphadenopathy, a wasting syndrome, opportunist infections like shingles, that is, herpes zoster, septicemia. And those things were added up and saying, well, this looks like immune deficiency, this looks like AIDS. But it wasn't really until we got a test that you could definitely say that somebody had got HIV infection and AIDS, really.
If we return to January 1983, could we please have on screen PRSE 0002647? These are the notes of a meeting attended by a number of Haemophilia Centre directors, not attended by you, Professor Lee, including Dr. Kernoff, on the 24th of January 1983. And to provide you with some context, it was a rather unusual meeting. It took place at a hotel at Heathrow Airport.
That is not unusual, because many meetings were held at airport hotels because it enabled, because haemophilia was rare. This is not in the context of this meeting, but many meetings were held of European treaters or American treaters. They would fly into a meeting and fly out. So having a meeting at a hotel is not at all unusual.
Well, if we just turn to the last page, we can see who was there. So if you just very quickly cast your eyes down the list of names, you'll see it involved the reference centre directors at the time, including Dr. Kernoff, but also a number of other Haemophilia Centre directors who were not reference centre directors, together with Dr. Krask and Professor Zuckerman. And the author of these notes is Dr. Bolton, we think, and then there were representatives from Immuno. Now, I'm not going to trouble you with the first part of the meeting minutes, just the second part, which looked at AIDS. Could we go to the previous page, please, Henry? So you'll see under the heading Acquired Immunodeficiency Syndrome, there's a summary by Dr. Krask of the current position. There's a description 2 paragraphs down of possible clinical features, including herpes viruses. And then it says up to the 10th of December 1982, some 800 people have been reported as suffering from the AIDS, and there was a 45% mortality. And then it says this: 10 hemophiliacs in the US have been affected, 5 have died, the youngest was age 7. All cases have had prolonged treatment with factor VIII, but there's no specific implication of one particular product or batch. Other cases involving blood and blood product transmission have included platelets transfused in 3 cases. In one of these cases, one of the donors was a young New York man in his 20s. A second case was a 20-month-old child who'd received several units, including platelets, known to have come from a homosexual donor.
That case was the case that I was talking about.
The San Francisco
when it was
case.
Written up, the paper itself. I think this is very clearly shown in the book called And the Band Played On by Randy Schultz, where he really exposes the transfusion head up in America. But that paper was sent around numerous journals and turned around because people didn't believe it.
Yes, I'm just.
So I'm saying that because there was debate. You know, people who review papers are experts.
The child, it's described, has developed a possible AIDS case. It's a 20-month-old child. Over the page, incubation period for the syndrome appears to be 6 months to 2 years. In the UK, so far, only 1 or 2 cases have been reported. The infectious precautions include, and then the various protocols in relation to donation are discussed. And then the attention of the meeting was drawn to the 2 articles on the editorial in the New England Journal of Medicine. We've looked at one of those. And reference there expressly to the T4-T8 ratios and issue about donor pools. Now, that's an update as at the 24th of January about cases in the States, including the case of the baby that you've referred to. Was that information, as far as you can recall?
I think you've missed out the critical line in this, actually.
Which line's that, Professor?
That second line. In the UK so far, only 1 or 2 cases have been reported from the Communicable Diseases Centre. I presume that's talking about haemophilia people with AIDS.
No, not at that stage, and I don't think I did miss it out. I think I read it out, Professor Lee. But in any event, no, not haemophiliacs at that stage in the UK.
Okay, well, it was during that year.
Yes, it was. Would you agree that the information set out there about the numbers of cases in the States and the cases from platelet transfusion was significant information which would support the idea of a link between transfusion and AIDS? Not prove,
well,
but support.
I think probably yes. It's not proof.
Did Dr. Kernoff report this information at one of the meetings that you've described? This is about the time you're joining the Royal Free.
This is January 1983. I'm not even there.
24th of January 1983.
Yeah, I'm not there. I said the end of January I started there.
Yes, forgive me, Professor
And I
Lee.
also don't... I really don't think it reasonable to ask me about a meeting in 1988... What is it? 1983.
January 1983.
That I wasn't at.
I'm trying to show you, Professor Lee, the state of knowledge as at January 1983 that would have been shared with Dr. Kernoff. And the question is, was that information that was disseminated by Dr. Kernoff amongst the staff at the Royal Free?
I have no idea. And what I would also say to you is to go back I would like to tell this inquiry about things I know about. I don't want to tell this inquiry about what Dr. Kernoff was thinking. I don't know what he was thinking, but what I do know what he was thinking when I was working with him. And I would go back to the Lancet paper in May 1983. And what I can remember, and this is a very clear memory, is before that letter was sent to the Lancet, he had a very clear discussion with me about what this means. That's after this paper. So that what I'm trying to get over to you is that was not the only view. I would also... It was emerging experience.
What discussions, if any, did you have with Dr. Kernoff, or Dr. Kernoff have with you, about AIDS in the first half of 1983?
We were continually talking about it because we were trying to understand what was going on.
So it's like...
But what I'm saying to you is the idea that everybody knew everything at that stage is wrong. And I'm trying to also... You know, the memory, the really powerful memory I have, mainly because it was the first international meeting I'd ever been to in my life, was this meeting in Stockholm where it was an ad hoc meeting. It wasn't even in the programme because people were trying to report their ideas. And these data were presented there and accepted. And people were still discussing, is everybody going to get it? There's no doubt that some people had got it. But it was certainly not clear that everybody was going to get it.
Professor Lee, at no point have I suggested to you or to any witness that everybody knew everything in 1983, in January 1983,
well,
or that
but
everyone...
I'm getting the feeling that that's what you are suggesting.
I'm trying to understand and ask you to explain what discussions took place in the early part of 1983 at the Royal Free Hospital. You are one of the few witnesses that we can ask that question of. If you cannot remember, then you cannot remember.
All I can say is I sat at this desk in my room and I'm looking at this information and trying to analyse it. I'm talking with Dr. Ritzer, maybe on the phone occasionally. And Peter is in his room down there, managing the department, and he clearly would come and see me and discuss things and what's the findings, what have you got here. So insofar as that, we were discussing AIDS. He also, as I said yesterday, he had this collection of references, this filing cabinet that anything that was a reference, he would stick the title or have the title stuck on a file card so that he can access references. So he would say, you ought to read this. So, we were discussing it. But I would also like to emphasize again, 37 years ago, you're trying to ask me what conversations I had with Professor Kernoff, Dr. Kernoff. And as I said, I have this very clear conversation about the data that was going to be put in 2 slides in Stockholm because, this was a memorable thing for me. And he was quizzing me on, are we sure, what's this all about? And we were kind of batting ideas around. That's the kind of thing we did.
In the course of 1983, the UK HCDO reference centre directors met. Information was sent to directors by Professor Bloom and Dr. Ritzer. The information was sent to Dr. Kernoff, and he was part of their decision-making process. Was that information that, as a matter of general practice, Dr. Kernoff would circulate amongst the department or summarise for the benefit of the department?
Well, we did have every Thursday morning for an hour, we had what was called a teaching session. And so that would be the kind of meeting where information was presented. So the laboratory might be talking about a meeting they'd been to, and they give feedback of new tests or something. And it might have been something he might have discussed then, but I don't recall. And I think also it's a little unfair asking me about meetings at which I wasn't at.
I wasn't asking you about meetings at which you weren't at then, Professor Lee. I was asking you what information was shared by Dr. Kernoff with those at the centre.
About a meeting at which I wasn't at.
No, about the advice that was provided by UK HCDO reference centre directors. Was that information...
I can't remember. It's 37 years ago.
I won't take you to the documents of the meetings that you weren't at, Professor Lee, but one of the things which reference centre directors asked directors to do in March of 1983 was to look out for signs of AIDS and to set up a reporting system so that information was fed back to Dr. Krask. As far as you can recall, was that something Dr. Kernoff asked you to do?
No. Don't think so.
But just before we get to the World Federation of Haemophilia meeting, which I think was the 27th of June to the 1st of July 1983, could we look at PRSE 000372? This is a document from the Council of Europe's Committee of Ministers. If you look at the heading, it was a recommendation of the Committee of Ministers to Member States on preventing the possible transmission of acquired immune deficiency syndrome from affected blood donors to patients receiving blood or blood products. And you can see from the italicised bit in brackets, it was adopted by the Committee of Ministers on the 23rd of June 1983. So this is just a few days before the World Federation of Haemophilia meeting in Stockholm, which you attended. If we could go to the second page, please. And could we just zoom in on the top part of the page? This is a recommendation at national level from Europe to member states, and you may not have seen it, of course, at the time, Professor Lee. But you'll see it says this: recommends the governments of member states to take all necessary steps and measures with respect to AIDS, and in particular, to avoid wherever possible the use of coagulation factor products prepared from large plasma pools. This is especially important for those countries where self-sufficiency in the production of such products has not yet been achieved. And then the second is to inform attending physicians and selected recipients, such as hemophiliacs, of the potential health hazards of chemotherapy and the possibilities of minimising these risks. So you'll see there, Professor Lee, that a few days before this World Federation meeting in Stockholm, the European Committee of Ministers recommended the avoidance, where possible, of the use of coagulation factor products from large plasma pools, and that not just doctors, but also hemophiliacs, patients, be informed of potential health hazards of chemotherapy. Was that something, as far as you can recall, that was discussed at the World Federation of Haemophilia in Stockholm a few days later?
I don't recall it.
Your evidence to the Lindsay Tribunal was that there were no changes to the approach to treatment at the Royal Free Hospital in 1983 or 1984, save that in 1984 there was at some point adopted, and you couldn't recall when, a policy in relation to deferring elective surgery. As that was your evidence to the Lindsay Tribunal, as you've said, when events were still fresher in your mind, is that likely to be correct?
I think that probably is correct, yes.
So,
I think also, as I said yesterday, the evidence I gave to the Lindsay inquiry 20 years ago, I was a working director of the centre and professor of haemophilia, and I actually had access to documents or treatment records. So I think it was accurate. And but again, I would emphasise that, you know, I wasn't in the business decision-making process through that period.
The discussion that took place that you referred to, the debate at the World Federation of Haemophilia...
It wasn't a debate, it was people from all over the world. It was an hour at lunchtime. It was chaired by Dr. Margaret Hill Gartner, she's died now, but she was a famous paediatrician in New York who looked after children with haemophilia. And before the meeting, and this request would have gone to Dr. Kernoff, not to me, he didn't go to the meeting. A request was made that if you had information to share, would you take information on no more than 2 slides? And the reason for that is, again, I would pick up a point that I made yesterday. You know, the dissemination of information now is instant. Then it was very, very slow. And so, and you may pick up on this in a later discussion about London. You know, meetings were instant, and that was where the information was being shared. So it wasn't a debate. It was a presentation, and what I was trying to say that there were different views presented.
Can you recall whether there was a majority view that the condition was likely due to an infectious agent?
There wasn't a vote taken or anything. What I do remember, I got my slides upside down, which is perhaps why I do remember it. But I also remember right up the back, there was a Canadian physician, I think he was called Zonkus, Tsoukas. And he talked at great length about lymphadenopathy syndrome. And you know, that was quite a dominant part of that meeting.
Can we move on to 1984 and a document that you authored? Could we have on screen, please, Henry, WITN 1003018, please? This is a Haemophilia Society publication, Hemofact, AIDS Release Number 3. It says this fact sheet contains important information concerning AIDS, 11th of May 1984. If we go over the page, we can see that the leaflet is authored by you. Can you recall how you came to write this? Who asked you to write it?
I think, I don't know, but I think certainly the request came from the Haemophilia Society, and I would imagine it must have gone to Peter, because they wouldn't come directly to me, and that Peter passed it on to me, and it's certainly what I wrote would have been reviewed by Peter.
As far as you can recall, were you given any kind of brief from the Haemophilia Society as to the kind of message they wanted conveyed?
No, they wanted information.
If we look at what you wrote here, you said the occurrence of AIDS in haemophiliac patients has strongly suggested transmission of the disorder by blood products. Epidemiological studies have suggested it may be related to a transmissible agent. And then you make reference to scientific developments in the States and in Paris. You say these reports should be received with optimism. The obvious benefits from such findings would be the provision of a blood test for both affected persons and donated blood, and in the long term, the development of a vaccine. You then say in Great Britain, the number of haemophiliacs who've been reported with AIDS remain at 2, thus the incidence is less than 1 in 1,000 patients at risk. I'll come back to that. You say the relationship of the immunological abnormalities found in many heavily treated haemophiliacs throughout the world is uncertain, and then refer to studies in Scotland, Australia, and America. You say it's possible that the immune suppression produced by repeated exposure to clotting factor concentrates lowers the threshold for infection with the putative AIDS agent. And there is then further discussion about that. And you suggest that this is a function of the characteristics of the final product and the fractionation methods used to make it. Thus, prospects for resolving these problems are brighter for haemophiliacs than for other high-risk populations, since improvements in plasma fractionation are likely to make it possible to remove or inactivate causal agents from the therapeutic products. And you say the heat-treating clotting factor concentrates which have been manufactured by many commercial companies in the NHS may be an advantage. And then you talk about the really good news, and you refer to work at the Royal Free Spadewood and in San Francisco about the synthesis of the the cloning of the gene for factor 8. Now, it could be said, and this is what I'm inviting you to comment on, Professor Lee, that this is an article which has a rather upbeat, positive, reassuring tone. Was that what it was designed to convey, to reassure patients?
No, it was written to convey what the knowledge was at that time, and the number of cases of AIDS in people with haemophilia in the UK at that time, was 2, and this has come from the Oxford records. As you said, people had to let Oxford know for the database, or not the database, the records. And when I write in here that the number at risk was 2,000, this was the number of people in the UK who had been treated with clotting factor concentrate at that time. So the incidence was 1 in 1,000. And in terms of the immunological change, I think I would like you if possible, if that's allowable, to pull up a paper. I'm afraid the number I've got is my witness statement, which is 655086.
What's the paper
And this
called,
was
please,
actually
Professor
published
Lee?
in 1996.
Is that comparison of immunodeficiency and
Yes.
age-defining conditions? Yes, it's WITN 0644086.
I think the reason I want to just put this up is because the discussion around immunological abnormality caused by blood transfusion and concentrates was quite significant in the time period that we're talking about. And indeed, it didn't go away in North America. There was a Professor Duisberg, who was still promoting this idea. And we had to publish a paper in 1996 to dispel it. What we did was we compared a group of our patients who were HIV negative, we had a test then, and a group who were HIV positive. And it was quite difficult, sadly, to find a number of HIV negative people who'd had a large amount of treatment at that stage, but we did manage to find it so that the two groups could be compared. And we showed that, I'm sure we would all think that that was what would happen. The people who were HIV positive were the people who got AIDS, and the people who were HIV negative didn't. Even so, when you read, I don't want to prolong this here now, but if you read the paper, this Duisberg is still saying, but even so, he's not believing it. So this is published in the BMJ, so it's been subjected to peer review. So the BMJ are not going to publish a paper about something that is not an idea, and that's 1996 when we've got tests for it. In 1983, we didn't have any tests, and so I don't think I should be representing somebody who's putting rose-coloured spectacles on what was a terrible health problem. What I was doing in this pamphlet was stating the facts and the view that was held at that time.
We know that...
and I would add that you keep asking me what Dr. Kernoff thought, and did I have discussions with Dr. Kernoff? He certainly would not have let this go to the Haemophilia Society without, looking at it. I would also, go back to the earlier discussion we had about the paper looking at immunological abnormality of these strange opportunistic infections and lymphadenopathy that we were seeing, but it was still discussing about whether it was immunological or whether we were going to see AIDS or whether those people were going to go on to AIDS. It was still not clear. And the other thing that's quite interesting here, there is such a parallel with COVID-19, isn't there? Because we're talking about there may be a vaccine. Well, of course, there never was a vaccine because it's a carrier state. But we never had any idea of that then. So I don't think people now with COVID are talking about we have a vaccine by Christmas maybe. We don't know. And I really do think it's important to try and understand that it's very easy with looking retrospectively, but it's very difficult to remember the confusion, the lack of knowledge at that time.
Do you think there might have been a risk that those reading this material might have felt reassured from reading it that very few people were likely to develop AIDS and that it was safe to continue taking factor concentrates?
Well, I guess on the face of it, there may be. But that, because you present facts as you know it, and that's how they're interpreted. I don't think one should massage and facts, these are the facts. There are 2 people in the UK who've got AIDS. There are 2,000 people who've been treated. Therefore, the incidence is 1 in 2,000. And then I go on to talk about the immunological changes, which undoubtedly there were. We were sitting there recording them. And people, because their lymphocyte count went down to less than 1,000, they got these strange things like shingles and streptococcal pneumonia in a young man who's unheard of. But if you've got immunological abnormality, it's there. And so we were learning. We were so learning.
Telling a lay audience, in the sense of non-clinicians, although no doubt many of those reading this were experts in their own care as haemophiliacs, but telling a lay audience that the incidence is less than 1 in 1,000 patients at risk, number of haemophiliacs remain at 2, may be factually correct. But what you don't go on to set out here is what the risk might be from factor concentrates of others, having transmitted to them what was by now surely thought likely to be, if not proven to be,
Well,
yet a transmissible infectious agent.
I would take issue with you. Patients with haemophilia are pretty expert because they go to meetings, they have bulletins from the Haemophilia Society. So, there was a lot of knowledge circulating around. So I think it's a bit patronising, really, to well, not patronising, but it's, of all the patients you have, they're probably the most educated about their condition because it's so rare, it's lifelong, and so they learn about it and they get information from the Haemophilia Society.
Yes, absolutely right about their bleeding disorder. They wouldn't be experts in AIDS or viral transmission.
They were getting as much information as was coming out by the Haemophilia Society. That's why they produced this bulletin to send stuff out. They were sending anything that came their way about this strange condition.
Could we just look, before we break, one further document, which is the Hemofact that followed up this. It's at WITN 10030019. This is the 24th of September 1984, so it's the next release. And this was, at the time, the Haemophilia Society's chosen method of communicating information to its members through these leaflets. This is authored by Dr. Kernoff, if we go to the next page. And I'll just ask if we go to the page after that, please. So he talks on the first page about the identification of LAV and HTLV3. And then the top of the page, he says, the presence of antibodies is usually taken as evidence of immunity to infection. And perhaps one reason why the risk of AIDS in haemophilia is so low, around 1 in 1,000, is that many patients are immune to it. Now, he's not there talking about incidence, he's talking about risk.
Well, I think that is incidence. That's the same figure that I had. I mean, I think you're playing with words.
Well, words can be rather important, Professor Lee, when they're the means by which patients understand if they're being exposed to the risk of a fatal condition. All I can say is that
in this context here, he is meaning incidence. It's the same, the risk of AIDS. Those are words he crafted, but he is meaning this is incidence, 1 in 1,000.
He says in terms, the risk of AIDS in haemophilia is so low.
Yes.
What's the basis upon which he could reasonably say that in September 1984?
I think I've got that. What he's saying is we have seen 2 cases, or something of that region, of AIDS, despite the number of haemophiliacs. I think you're right, Professor, that he uses the word risk where he ought to have used the word incidence. And it may be, it's a matter of comment or a matter of conclusion for me, whether I come to the view that really the risk of AIDS is something very different from the
Yeah.
incidence of AIDS. And it may be that somebody reading it without having, as it were, a dictionary to one side, might have said, well, the risk to me is very, very small. And that might be the way that somebody might read it, I suppose. But that's a matter for me, ultimately. It's time for a break, I think.
Before we go for a break, can I
Yes,
just
certainly, of
comment
course.
on what's written here? I mean, what is interesting is the presence of antibodies is usually taken as evidence of immunity to infection. And perhaps one reason why the risk of AIDS and haemophilia is so low is that many patients are immune to it. When we come, well, I don't think you'll be questioning me on this because I never gave results out, and I think you have a statement being made by Dr. Eleanor Goldman, who was associate specialist in the centre, and it's my understanding, I think I put this in my statement, that when patients were given the result of their HIV test, that some of them were, or they maybe all been told, I don't know, because I didn't do it, but that they might be immune. And of course, you know, now we know that there's a carrier state, so it doesn't mean you're immune.
It may be thought it's something paradoxical about it there being a disease of the immune system, or a disease which results in immune misfunction, which also produces an immunity to something else. But that's for others to perhaps consider, and perhaps for me to consider. But let's take a break, shall we?
Yeah.
And that's come back at 10 to 12. 10 to 12.